I'm Dr. C.B. Vijaykumar from AIIMS Bhopal. I'm doing residency in forensic medicine and toxicology. Today I'm going to discuss about organophosphorus. I am going to give a brief introduction about it. Organophosphorus compounds are a diverse group of chemicals which includes insecticides like malathion and parathion, etc. And it also includes nerve gases like soman, satin, tabun and VX. These components are synthesized early in the 1800s in Berlin and Schrader in Germany, which are used as insecticides, basically commonly used for killing insects. And however, German military prevented the use of organophosphorus because they wanted to use these in military as a warfare agents. So what is warfare agents? Warfare agents can be defined as chemical substances, whether gaseous, liquid or solid, and biomedical products such as microbes and toxins, which might be employed because of their direct toxic effects on man, animals and plants. This includes chemical warfare agents, and these chemical warfare agents are considered as the most toxic compounds. In this chemical warfare agents, there are lots of classifications, and the main classification, which is the nerve agents. This nerve agents basically belong to the organophosphate compounds, which inhibits tissue cholinesterase in humans at even small dosages. So it is considered as very toxic. There is a history regarding this. On March 20, 1995, a terrorist attack has been happened in Tokyo, Japan, where almost 12 people were killed and almost 3,000 to 4,000 people were traumatized due to these attacks. I will show a little video on this, which shows that
an invisible terror, an unthinkable act. With the thousands of Tokyo Koreans returning to work, the unthinkable became a terrible reality on Monday morning. They staggered out of the subway, eyes streaming, noses bleeding, many collapsing. Others suffered convulsions and vomiting. 6 people were killed, poisoned by gas canisters left on several trains. 10 more cyclists were comatose, badly affected by the deadly gas which spread through the carriages. Rescuers in protective suits were swiftly on the sea, lessons learned from the Kobe earthquake. It seems the fuels contained carrion, a nerve gas developed in Nazi Germany, said to be 500 times more toxic than cyanide.
You can see in that video, they themselves mentioned that it is 5,000 times more toxic than cyanide. And when they investigated those cases, they can't find sarin in the victims of those cases, because they have concluded by saying that this sarin has passed through the blood-brain barrier and get distributed inside the brain tissue. On exposure to these compounds on high concentrations, the usual symptoms we develop is neurobehavioral, cognitive and neuromuscular damages, which is related symptoms. And the first evidence of this syndrome, this type of psychopathologic neurologic lesions, were first reported by Spiegelberg, who worked on production and handling high toxic nerve gases in Germany. According to symptomatology, the groups were divided into two. One group has persistently low vitality and ambition, defective autonomic regulation, which leads to cephalgia, gastrointestinal and cardiovascular symptoms. The second group is classified according to symptomatology, but this has still more extra symptoms like depressive or subdepressive disorders of vital function, cerebral vegetative attacks, slight or moderate amnestic or demential effects. So according to symptomatology, the groups have been divided into two, and basically it was manufactured for the use of agricultural field, and it's been used since World War II. The function of this is which I have already told, it usually inhibits the acetylcholinesterase enzyme, and even in insects, it also performs the same action. In insects, the nerves of some of the nerves uh, contains this acetylcholine, and this when organophosphate combines with that, it causes muscular cell contraction, etc. And acetylcholine stimulates the muscle cell to contract, and which I have already told, and due to excessive contraction, the insect dies. And organophosphates are acutely toxic because they chemically bind to the acetylcholinesterase enzyme in such a way that it cannot destroy acetylcholine, and the insect dies with its muscles in a prolonged state of contraction. The use of pesticides have led to massive increase in fruit production, significant reduction in crop losses, and improved yields among many other advantages. And it not only affects insects, but it also affecting the humans, as acetylcholine is also one of the chief component in humans. And due to its widespread use in the community, there is bioaccumulation of pesticides in the environment, and organochlorine pesticides, which was used for a long time before, now it is stopped because it's long persistence in the nature, and nowadays only organophosphorus and carbamates are used. But even though the advantages are more than the organochlorine components, this has carcinogens and mutagens, which is harmful for us. And how we are exposure to these components are via dermal absorption or inhalation or oral ingestion. So the other effects which are caused by this to the humans are high genotoxicity, hepatic dysfunction, embryotoxicity, teratogenicity, and induction of neurobehavioral and neurochemical changes, as well as interfering with vitamin D3 metabolism. And many studies have even found the association between organophosphorus and increase in the incidence of chronic diseases like cancer, birth defects, reproduction disorders, neurodegenerative, cardiovascular, and respiratory diseases. And also one of the study which proved the association between the organophosphorus and increase in the risk of obesity and type 2 diabetes mellitus. And another studies which says that this can also lead to childhood overweight and obesity. And these obese children have worse psychosocial health and are more likely to be overweight or obese as adults, with an increased risk of developing cardiovascular disease or type 2 diabetes. Opsogenes are chemicals that inappropriately alter lipid homeostasis and may increase susceptibility to weight gain across the lifespan, particularly when exposures occur during susceptible periods of development such as prenatal period. These organophosphorus are considered as absogenes, as this increase the weight of the children whose parents were exposed to organophosphorus during the conception. As I already discussed about the environmental features and environmental hazards of the poisoning. Although there were almost 1.5 million tons of pesticides being manufactured, irrespective of all this, because of its usefulness in the agriculture. And extremely hazardous pesticides are also available in many developing countries. Even in India, if you have seen in many Indian markets, you can easily get these hazardous pesticides even without any prescription, and they are selling at selling at the back. So these chemicals are many of these hazardous chemicals are actually banned in for many developed countries. And it also not only they are used in warfare, wars, or environmental hazards. This also is used for suicidal attempts. And studies says that OP poisoning in India, the suicidal intentions were found to be 67.4%, And in an Australian study, it is said that 36% of patients had suicidal intentions while consuming this OP poison. And also another study says that National Insurance Report, which says that pesticide injuries range from 70,000 to 80,000 annually. Now coming to Indian scenario, in North India, the common poisoning is considered to be aluminum phosphide, and in South India, it is considered as organophosphorus being considered as the most common poison. And this is one of the study which is conducted by a doctor who is working in AIIMS Bhopal while he was working in Rewa, Madhya Pradesh. Which this was a 2-year study from 2010 to 2012. In this, almost 550 cases were analyzed. Among the 550 cases, organophosphorus were leading. Almost 128 cases were organophosphorus in their study, and the fatality rate is only 7.03 compared to the other poisons. And this is the data of our AIIMS Bhopal PIC Poison Information Center. For this is the data of 4 years from 2019 to 2023, and in this among the category of agrochemicals, there are 176 calls were received. In this agrochemicals, organophosphorus, the number of organophosphorus poisoning related calls we received almost 25, which is quite a number. And I think this is the most most calls we have received for this organophosphorus poisoning. And by this I am finishing my basic introduction and of organophosphorus. And thank you. This is a reference I have used for the presentation.
A very good afternoon to one and all present here. Myself, Dr. Ram Kumar, JR, second year pharmacology, Department of Pharmacology. So, the topic given to me for this ITS 5th session is mechanism of action of organophosphates and newer methods and drugs for the treatment of the same. So, I'll be talking on this outline. So, first I'll be talking about what are these cholinesterases. Then I'll be moving on to cholinesterase inhibitors. Then we'll see where we can fit this OPCs in this classification. Then we'll talk about their mechanism of action, and further we'll move on to the newer methods for the treatment of OPC poisoning. Then finally I'll summarize my session. So moving on to the topic proper. So cholinesterase. So these enzymes belong to the family called serine hydrolases. So their main role is to split the neurotransmitter acetylcholine into acetate and choline. See, we have two types of serine hydrolases. One is acetylcholine esterases and the butyrylcholine esterases. We'll see the difference between both of them in the next slide. So basically, as we can see the weight difference. The main difference, even though they both show 50% structural similarity, the main difference is their site of location. This butyrylcholine esterases, they are in the plasma and liver, whereas this acetylcholine esterase, it is present in RBC cell membranes and nerve terminals and synaptic cleft. So the other than one important point is the rate of metabolizing this acetylcholine, where as you can see, it is very high in case of acetylcholine esterases, whereas this it is very low. Per se, like we can say, butyrylcholine esterases, they do not metabolize naturally occurring acetylcholine. They metabolize only the drugs like cocaine, succinylcholine, like that. So that is the main point we have to infer from this differentiation. And one more thing here I would like to add is this acetylcholine enzyme, acetylcholine esterase enzyme. It is coded by a single gene that which is located in chromosome 7, long arm of chromosome 7. That is the point here I want to add. Then moving on to the next, we can see the structure of this acetylcholine esterase enzyme, which has two parts. One is two sides. One is anionic site and the aesthetic side. Our in this slide itself, we can make out the metabolism of acetylcholine. As you can see, this acetylcholine binds to both the site, both the esteritic site and the anionic site. So this esteritic site, they take care of this ester bond. They hydrolyzes the bond, so it can split the acetylcholine into two parts, acetic acid and choline part. So that we can see in this slide. So this is the basic structure of acetylcholine esterase enzyme. So next we will see the choline esterase inhibitors. What are the inhibitors we have? So it's just a classification based on reversible or irreversible, how they binds to the enzyme. So as we can see, in reversible we have carbamates, and also in irreversible also we have carbamates. This OPC, here we have to concentrate on the OPC compound mainly fixed in the irreversible cholinesterase inhibitors. So with that, we'll move on to the next topic. So as we all know, organophosphates, they are organic compounds containing sulfur in containing phosphorus. Containing phosphorus in them, and their general formula is this, wherein you have a phosphate central group which binds with the oxygen atom, and they have two alkyl groups. Here you can see this X. It denotes the leaving group. For example, if this OPC reacts with some compound, what is the compound leaving from this leaving from this group? That is the thing denoted by X. So based on this X, they are classified into 4 groups, as you can see. So A, B, C, D. This is taken from Goodman and Gilman textbook of pharmacology. So you can see that in group A, the leaving group is halogen. In group B, it is alkyl thio. Like that, it is classified into 4 groups, and you can see the examples also. So in group A, we have tabun, serine, some all the nerve gases will be there. One more nerve gas, VX, will be in group B, but it is a nerve gas, but it comes under group B. So all that classification is just to show that structure activity relationship of this compound. So based on this structure, they behave separately. So in this slide, we can see the mechanism action of OPCs. So already I told acetylcholine binds to both the anionic and esteric side, where this OPC binds only to the esteric side, which you can see in this image. So once this esteric site is occupied, either two things can happen. One thing, the enzyme can be inhibited irreversibly, or the enzyme can go spontaneous reactivation. The two things can happen. So once, if the enzyme is get irreversibly inhibited, that process we call it as aging. That you can see in this image. So aging means once the compound gets covalently bonded to the esteric side, it starts losing its alkyl group one by one. So just by losing the alkyl group, the phosphate bond with the esteric site, it's strengthened, progressively it is strengthened. So that by that, the enzyme substrate complex will become more resistant, or what do you say, more stable to the hydrolysis. It will not be hydrolyzed easily. That is the thing, we call it as aging. So once this aging happens, the enzyme then solely the complex they should wait for the new acetylcholine esterase enzymes to come and destroy the acetylcholine that is left in the synaptic cleft. So this is the point we have to take it from here, that is aging concept. So moving on, so this is what I earlier told. Either it can go for spontaneous reactivation, or it can go for aging and it gets irreversibly inhibited. So that sums up the mechanism action of OPCs. Then we will talk about the newer methods and drugs for the treatment of OPCs. So the current scenario, so till date the FDA approved treatment for OPC is that we have atropine, AIIMS and benzodiazepines. These three are the mainstay of the treatment for the OPC poisoning. But still we have some issues like poor CNS penetration by the both atropine and AIIMS. And this AIIMS, they like what do you say, if we give oximes, it is not general to all the OPCs, it will go and reactivate the enzymes. So these oximes are also agent specific. For example, it will react separately to separate nerve gases like tabun, sarin, like that. It responds to the different agents differently. That is the thing. Then limited stability. Once we give this oximes, it immediately get oxidized to its inactive form. That is the one issue we are facing with oximes. Then as we all know, there is if there is a delay in the treatment of OPC poisoning, we know the prognosis is also directly proportional to the delay. So poor prognosis in delay management, this is the current scenario. That is why we are expecting a recent advances in OPC managing. So for this recent advances with the basic strategies is that we can see, like we have to reduce the time of atropine administration to the patient. So for that, the few strategies are made that we will talk about later. Then so all the drugs what we are having are morely acting on the peripheral receptors. Their CNS penetration is low. So just to increase CNS penetration, some strategies are made that we will see, and to find novel agents rather than depending on atropine and oximes, we can go for novel agents which will be more specific and more efficacious than the available current treatments. So we will see one by one. So in atropine, to minimize the duration, to minimize the time lapse, they have made some strategies like nasal spray, nasal drops, dry powder inhaler, fast integrating sublingual tablets. As we can see, this is for example, the route of administration of atropine is IM, either IV or IM. So that a layman cannot do at the site of poison injection. So at those places we can have this kind of alternatives. So to where a layman can administer this kind of formulations to the patient, so the time lapse will be reduced. So the prognosis might be increased. That is the advantages of this formulation. These formulations are under trial. Then moving on to oximes. So first in oximes, just to increase the CNS penetration, they have made some sugar oxime conjugates. So this sugar oxime conjugates have more CNS penetration. And one more concept is this Zwitter ion concept. So Zwitter ion, this this renders more CNS penetration to the oxime compounds. Then we can give intranasal obidoxime. So intranasal, it acts more faster and more bioavailability will be more. And there are some phenoxyalkyl substituted pyridinium oximes also there. These are the these strategies are made to increase the penetration of CNS penetration of the oximes. Other than that, with the oximes, researchers are going on novel oximes like these compounds K203, RS194B. These oximes are also under trial. So that is the thing about oximes. So rather than depending on oxime reactivators, we can go for non-oxime reactivators. That is the current study going on. Like they found this anti-malarial drug amodiaquine and its analog ADOC. They both have this reactivating action. So reactivating action of paraxon, sarin and DFE. So their acetylcholinesterase reactivating activity is more superior when compared to pralidoxime. So this can be a future like milestone in OPC management, non-oxime reactivators of acetylcholinesterase enzyme. So then moving on to the drugs under pipeline for this OPC management. All these drugs are used as adjunct. They are not like a substitute. They are these drugs were under trial for adjunct to the atropine therapy. For example, analogs of acetylcholine, magnesium sulfate along with atropine, N-acetylcysteine, human butyryl cholinesterase. This they are suggesting that it can be a bioscavenger of that acetylcholine OPC compound. like that they are suggesting. So, and ketamine along with the midazolam, it is being tried for CNS toxicity like status epilepticus and seizures. So these are the drugs under trial. Then this is a newer compound called ganaxolone. So it comes under neurosteroids. So previously we have some neurosteroids called allopregnanolone. The problem with allopregnanolone is less bioavailability, more CNS lipid, what do you say? More less bioavailability, shorter duration of action, and it has some metabolites like ketosteroids, which are more side effect, they act on more receptors and cause more steroidal side effects to the patient. So what they have done is they have taken that allopregnanolone and they made some substituted and prepared this drug called ganaxolone. It has more half-life, more bioavailability, and more and less steroidal side effects. That is the one point. Coming on to the mechanism action of this drug, we can compare this with midazolam. Midazolam acts on GABA A receptors. So one thing I want to add is GABA A receptors, as we all know, there are two compartments. One is synaptical GABA A receptors and the extrasynaptic. Our midazolam acts on this synaptical GABA A receptors, whereas this ganaxolone acts on both synaptic and extrasynaptic, so thereby it inhibits both phasic and tonic currents. So it is that's why it is considered more superior to midazolam in case of seizure status epilepticus management in a OPC poisoning patient. So to summarize my presentation, so since for the last 20 years, the basic management of OPC poisoning is based on atropine and AIIMS. So still it is a demand for a novel therapy. So our role is to find a new some novel therapies and approaches for this OPC management. So with that, I will end my presentation. Thank you.
Good afternoon everyone. I am Dr. Maya, JR from General Medicine, presenting clinical features, the symptoms, management and care of organophosphate poisoning. Clinical manifestations and mechanism. We read receptor-based clinical manifestations, time-based and the organ-based clinical manifestations. Receptor-based clinical manifestations are mainly organophosphorus act through the peripheral receptors and the central receptors. The central manifestation, that is anxiety, restlessness, ataxia, convulsions, insomnia, dysarthria, tremors, coma, respiratory depression, circulatory collapse. These manifestations occur mainly through the muscarinic receptors that are mainly present on the central nervous system. In central nervous system, all the muscarinic receptors are present along with the nicotinic receptors. Sludge symptoms, that is salivation, lacrimation, urination, defecation, GI upset and the emesis. These also occur through the muscarinic receptors, that is mainly through the peripheral muscarinic receptors, mainly M2 and M3. The neuromuscular symptoms, that is fasciculations and the paralysis, acts through the N1 nicotinic receptors that are mainly present on motor end plate. Sympathetic manifestations, that is increased heart rate, tachycardia and the hypertension mainly occur due to the N2 nicotinic receptors that are mainly present on the ganglia of the parasympathetic nervous system. Time-based manifestations, that is acute manifestations, delayed manifestations and the late manifestations. Acute manifestations occur within minutes to 24 hours, that is muscarinic, nicotinic and the central manifestations that we already discussed. Muscarinic, that is sludge, bradycardia, hypotension, meiosis and the bronchospasm. Nicotinic actions, that is weakness, fasciculations, cramps and the paralysis. Central manifestations, that is anxiety, restlessness, convulsions and the respiratory depression. Delayed manifestations, which occur between the 24 hours to 2 weeks. Late manifestation, which usually occur beyond 2 weeks, that is type 3 paralysis, which we will discuss later. Cerebellar manifestations, ocular and the ENT manifestation and the neuropsychiatric manifestation block. In organ-based manifestations, first we discuss respiratory manifestations. Patient might have a direct effect on medulla and the midbrain, that is decreased respiratory drive and glial cell inflammation. Patient might have muscarinic cholinergic stimulation leading to bronchospasm and the bronchoria. Possible increase of pneumonia secondary to cholinergic disruption of immune system. Patient might have nausea and vomiting. Stimulation of muscarinic receptors can increase gastric acid secretion, which further leads to risk of aspiration. Patient can have decreased phrenic nerve activity and therefore decreased diaphragm contraction, increased alveolar fluid and increased pulmonary capillary permeability. Alveolar hemorrhage can be there, increased alveolar protein, neutrophils and inflammatory cytokines, which further leads to ARDS-like picture. Overstimulation of the skeletal neuromuscular junction causes fasciculations and paralysis. There is also risk of increased risk of pancreatitis and the ARDS-like picture. Neurological manifestations. 3 different types of paralysis are recognized based largely on the time of recurrence and their different pathophysiology. Type 1 paralysis or acute paralysis, type 2 paralysis or intermediate syndrome, type 3 paralysis or organophosphate induced delayed polyneuropathy. Type 1 paralysis or acute paralysis, this is seen during the initial cholinergic phase. This is when large number of both muscarinic and nicotinic receptors are occupied acetylcholine, leading to persistent depolarization at the NMJ neuromuscular junction. Clinical features include muscle fasciculations, cramps, twitching and the weakness. At this stage, patient may require ventilatory support due to the weakness of respiratory muscles, leading to respiratory depression and the arrest. Type 2 paralysis and the intermediate syndrome. This is a distinct clinical entity that occurs 24 to 96 hours after the ingestion of OP compound. Approximately 10 to 40% of the patients treated for acute poisoning develop this illness. The onset of intermediate syndrome is often rapid with progression of muscle weakness from the ocular muscles, from the neck muscles, that patient not able to flex the neck, with involvement of proximal limb muscles and ultimately leading to respiratory muscles involvement, that is intercostals and the diaphragm, which occurs over the course of 24 hours. Type 3 paralysis or organophosphate induced delayed polyneuropathy, which usually occur sensory motor distal, that is sensory motor distal axonopathy, that usually occurs after ingestion of large doses of organophosphate compound. The neuropathy presents at weakness and ataxia following a latent period of 2 to 4 weeks. Initial stimulation causes excitatory fasciculations, which often progress to inhibit cause paralysis. The cardinal symptoms are the distal weakness of the hands and the feet. This is often preceded by calf pain and in some cases paresthesia of distal part of the limbs. Delayed CNS signs are tremors, anxiety and the coma. Other organ specific manifestations are cardiovascular complications, that is hypotension or the bradycardia. ECG manifestations include prolonged QT interval, elevation of the ST segment, inverted T waves and a prolonged PR interval. Rhythm abnormalities such as sinus bradycardia, ventricular extrasystoles, ventricular tachycardia and the fibrillations. Now we discuss the management of OP poisoning will be reduced. Diagnosis of OP poisoning. Diagnosis of OP poisoning is mainly based on history of exposure to organophosphorus compounds, characteristics, manifestation of toxicity, and the improvement in signs and symptoms after administration of atropine. There can be a pungent garlic-like smell. Toxicology analysis of the secretions, that is gastric secretions, blood or the urine sample. Serum and pseudocholinesterase level in the patient's blood samples will be reduced. However, in doubtful cases and especially if lab facilities are not available, we give 1 milligram of atropine intravenously. If this doesn't produce marked anticholinergic manifestations, then anticholinesterase poisoning should be strongly suspected. The treatment part. After initial stabilization of the patient, that is airway, breathing and the circulation, only after patient is stabilized we go for decontamination and the other supportive therapy. In supportive therapy, we had blockade of muscarinic activity, that is with atropine, reversal of cholinesterase inhibition, that is done with the help of AIIMS, correction of metabolic abnormalities, prevention of infection that might be needed in patients with patients who need prolonged ventilation, and management of complications. Decontamination and the supportive therapy. Patient to be kept in left lateral position with necks extended. This help to prevent the aspiration risk in the patient. Remove the clothes and clean the body with soap and water. Gastric decontamination is done by forced emesis if the patient is awake. We should avoid forced emesis if the patient is if patient is unconscious. Gastric decontamination can also be done through the gastric lavage. Care should be taken by the health professional to avoid decontamination. OP poisoning patient, if presents within 2 hours of ingestion, if patient is conscious, we should go for gastric lavage with the activated charcoal. If patient came in altered sensorium, then we should secure the airway first through intubation. Then we should go for gastric lavage and with activated charcoal. If patient present after 2 hours of ingestion or if the patient is conscious, then we should go for again the decontamination part. If patient is in altered sensorium, then we should secure the airway first, then should go for decontamination. The management part, it includes the 4 components, that is decrease absorption. Absorption of toxin should be decreased through the skin and the gut. After absorption, the organophosphorates make compound with the acetylcholine esterase enzyme and it acts on the various organs. It acts on heart and causes arrhythmias and long QTC interval. It acts on muscles, causes oxidative stress. Acts on respiratory group of muscles, causes bronchoria and the bronchospasm, and on the CNS, causing respiratory depression and the seizures. These are the various organs, that is atropine, diazepam, clonidine, adenosine, and the other group of drugs which modulate the effect of this organophosphates on various organs. Third part is that is we can neutralize the toxin by AIIMS and the butyryl choline esterase enzyme and the albumin, which is present and which can be provided through fresh frozen plasma. Other than that, we can enhance the elimination of the toxin by alkalinization, by the hemoperfusion, or the bioremediation, which uses the hydrolysis enzyme which hydrolyze the organophosphorus compound. Atropinization, we obtain IV access and give 1 to 3 milligram of atropine as a bolus, depending on the severity of clinical manifestations, followed by infusion rate. Our aim is to keep the systolic blood pressure above 80 mmHg and the urine output above 0.5 ml per kg per hour. We record pulse rate, BP, the pupil size, the presence of sweating, and the auscultatory chest findings after the first atropine dose. We review after 5 minutes. If after 5 minutes response is not there, then we have to double the dose. We have to review every 5 minutes. Once parameter have begun to improve, then we can cease the double dosing and we can continue with the same dose, or the smaller doses can be used. What are the target endpoints for atropine therapy? Clear chest on auscultation with no wheeze is the best sign of atropinization. Heart rate more than 80 beats per minute. Systolic blood pressure more than 80 mmHg. Pupils which are no longer pinpoint, that is dilated, mid-dilated pupil, and the dry axilla. First 3 points are the most important points for atropinization, that is target endpoints, that if these are present, we can stop atropine. Once the patient is stable, we can start infusion of atropine, that is every hour we have to give 10 to 20% of the total dose needed to stabilize the patient. Along with it, we have to watch for atropine toxicity, that is if patient is having any fever, patient having tachycardia, absent bowel sounds, or the urinary incontinence. If this happens, we have to stop the infusion and wait for 30 to 60 minutes for these features to settle before starting again at a lower dose. Adverse reactions to atropine. 2 types of adverse reactions to atropine can occur, that is allergy and the toxicity. Toxic results mainly from the anti-muscarinic effects, which can vary from person to person depending on sensitivity to atropine. Allergic reactions are rare, which are local manifestations after administration of eye drops, and systemic manifestation in form of anaphylaxis. Atropine toxicity is not uncommon with OP poisoning, which is manifested as tachycardia, tachypnea, increased body temperature, and the CNS stimulations like restlessness, confusion, psychosis, and the delirium. Seizures is rare manifestation of atropine toxicity. If these are present, then we have to switch over the glycopyrrolate, since glycopyrrolate doesn't penetrate CNS and doesn't have this CNS manifestations. Small doses of benzodiazepine may be required, and in severe cases haloperidol can be used, but there is a risk of neuroleptic malignant syndrome with haloperidol. Glycopyrrolate does not enter CNS, so initial muscarinic signs like coma or drowsiness might not be responded. Its use is recommended when there is copious secretions as an adjuvant to atropine, when there are features of atropine toxicity like delirium, which are confused with the CNS effect of poison. When atropine is not available, then we can go with glycopyrrolate. Dose of glycopyrrolate is 7.5 mg in 200 ml of saline, started as an infusion and titrated to the desired effect of dry mucous membrane. Neutralizing toxin, that is oxime therapy. Oximes act by reactivating acetylcholine esterase that is bound to the organophosphorus molecule. Pralidoxime is the most frequently used oxime worldwide. Other are obidoxime and the trimidoxime. The therapeutic window of the oxime is limited by the time taken for aging of the enzyme and the organophosphorus complex, because aged enzyme can no longer be activated by the oximes. Dose for pralidoxime is WHO recommends pralidoxime dose of 30 mg per kg bolus IV over 20 to 30 minutes, followed by infusion rate of 8 mg per kg per hour. Infusion is continued until recovery, that is 12 hours after atropine has been stopped and the butyrylcholine esterase activity is noted to increase. Largest oxime that can be given is 2 gram loading dose, followed by 500 mg per hour maximum for 5 to 7 days. We should avoid rapid administration of pralidoxime, because it can lead to tachycardia, laryngospasm and the muscle spasm and transient neuromuscular blockade. Other adjuvants which can be used for the treatment of organophosphorus poisonings are magnesium sulfate. It acts on the calcium channels, which further leads to decrease in the acetylcholine release. It decreases the CNS overstimulation by acting on NMDA receptor also. It is given in a dose of 4 gram on first day, and it has shown to decrease hospitalization period and overall improvement in mortality. Diazepam, as such, diazepam has no role in organophosphorus poisoning, but is mainly used for seizures, which can occur as organophosphorus side effect or atropine toxicity. Its dose is 10 mg IV slowly, which can be repeated up to 30 to 40 mg over 24 hours. Clonidine, it is alpha-2 adrenergic receptor agonist. It reduces acetylcholine synthesis and release from presynaptic terminals. Its dose is 0.15 to 0.3 mg IV bolus, followed by 0.5 mg over 24 hours. Charcoal hemoperfusion, its benefit is mainly shown in patients who present within 6-4 hours. After 24 hours of presentation, it has no such benefit, which is seen in most of the trials. Lipid emulsions, albumin and the FFP has as such no such benefit. Some study shows benefits, some study shows no benefits of these compounds in treating organophosphorus compound. Worldwide mortality of organophosphorus poisoning is 3 to 25%. Mortality rates mainly depend on the type of compound used, the amount ingested, general health of the patient, delay in discovery and transport of the patient to the required to the tertiary care hospital, insufficient respiratory management, delay in intubation, and failure in weaning of ventilatory support. Thank you.
Good afternoon, everyone. Myself, Dr. Gautam, Senior Resident DM, Critical Care Medicine from AIIMS Bhopal. The topic of discussion today is clinical features and emergency management of organophosphorus poisoning. So the flow of my talk will be what is the current statistics of organophosphorus poisoning in India? What is the mechanism of action of organophosphorus poisoning and how it manifests? What are the types of organophosphorus compounds? Why it is important to know what compound it is and how it is important to prognosticate and how it decides the mortality of the patient? What are the clinical manifestations? And what is the emergency management which we are supposed to do on timely basis in the emergency department? So coming to the current stats, we are all aware throughout the world, Asia ranks top among the usage of pesticides, contributing around 50 to 60% of pesticide usage in the world. In India, Maharashtra and Uttar Pradesh is using pesticide on a very large scale. The pesticide consumption by the farmers is on a very large scale compared to all the other southern and northern states. Though the consumption of organophosphate is predominant by the Uttar Pradesh and Maharashtra, the predominant cases are seen in Tamil Nadu, Kerala and Karnataka. So among all the pesticides, including fungicides, bactericides, herbicides, weed killers, insecticides ranks top in human poisoning. So this is the statistical analysis of all the states showing human poisoning cases with organophosphorus, where this is the status of 2022, where Kerala ranks first, followed by Tamil Nadu and Karnataka. So coming to the common classification of pesticides based on the chemical composition and target organism, it is divided into organochlorine, organophosphate and pyrethroids. These are the three most common compounds which we face in the emergency department. And based on the target organism, it can be divided into herbicide, insecticides, fungicides, bactericides and rodenticides. So today the topic of discussion is insecticide. So this is a list of organophosphorus compounds which are commonly used compounds of parathion, chlorpyrifos, diazinon. Here in AIIMS Bhopal we get cases of chlorpyrifos and parathion on a common basis. Uncommon organophosphorus compounds are phosphate, phenyltriathion and tetrachlorphenphos. So this is the WHO classification of organophosphorus compounds based on its toxicity, classified into highly toxic, moderately toxic and mildly toxic, among which the commonest compound parathion comes under highly toxic, followed by chlorpyrifos, which is moderately toxic. So we usually get only these cases, highly toxic and moderately toxic, and the mildly toxic compounds are usually used in the household repellents, insecticide repellents. So coming to the physiology of neuromuscular junction, to understand how organophosphate poisoning acts, so we should understand how this works. When the action potential reaches the presynaptic neuron, the calcium channels open and the calcium starts getting influxed. The calcium opens the synaptic vesicles and all the acetylcholine from the synaptic vesicles gets released through the process of exocytosis. It reaches the synaptic cleft, starts binding on the acetylcholinesterase receptor on the postsynaptic neuron. Once it sits on the acetylcholinesterase enzyme, it starts opening up the sodium channels and the sodium influx starts leading to the depolarization of the muscle. So the muscle action potential manifests there and that leads to the muscle contraction. So this is the normal mechanism of how acetylcholine is being synthesized, stored, released, and it causes muscle contraction. So before knowing how OP compound is manifesting all the muscarinic and nicotinic symptoms, we should understand what is the structure of this acetylcholinesterase enzyme, because all the management of OP poisoning depends on this enzyme. So it is a 12-stranded mixed beta sheet surrounded by 14 alpha helices. It has got two important sites, which is anionic site and esteric site. In normal physiological condition, the acetylcholine molecule sits on both the anionic site as well as the esteric site, and it gets broken down by the acetylcholinesterase enzyme into acetic acid and choline in fraction of seconds. This acetylcholinesterase enzyme is seen predominantly in RBCs, plasma, as well as the synaptic cleft in the central nervous system and the peripheral nervous system. So coming to the organophosphorus compound, it sits only on the esteric site of the acetylcholinesterase enzyme competing with the acetylcholine. So there occurs competition between the organophosphorus compound and the acetylcholine for the esteric site, but the anionic site is let free. We'll see the significance of how to utilize that anionic site in managing the patient. So once it sits on the esteric site, it forms a very strong complex. It starts inhibiting the enzyme. So the acetylcholine, which is released from the presynapse, doesn't get broken down by the acetylcholinesterase enzyme. It starts accumulating. That leads to excess of muscle depolarization, later followed by relaxation. So the muscle lands up in relaxed phase or hyperpolarized phase. So the patient develops severe muscle weakness, including respiratory muscle weakness, leading to the respiratory failure. So the organophosphorus compound, once it enters the body, it gets metabolized into some inactive metabolites, and majority sits on the acetylcholinesterase enzyme and starts inhibiting that enzyme, which is a reversible acetylcholinesterase inhibition. So whether this reversible inhibition will become irreversible or not, that depends entirely on what compound the patient has taken and how soon we give oxime to that patient, and what and how long it's been since the patient has consumed the poison. So these are the compounds, commonly consumed compounds by the patients. There are 6 compounds here: parathion, paroxone, quinalphos. The A, B, C first 3 compounds are the ethyl compounds. The fourth D1 is the methyl compound, and the last 2 are the atypical compounds here: profenophos and prothiophos. Among the ethyl compounds, parathion is the most common poison we encounter here. We hardly encounter methyl poisoning, methyl compounds, and we had encountered 3 to 4 cases of profenophos poisoning in AIIMS Bhopal. So what is the importance of these methyl, ethyl and atypical compounds? It decides the aging factor of the acetylcholinesterase enzyme. For example, the aging half-life of this methyl compound is around only 3 hours. So if a patient has consumed this methyl compound monocrotophos, and if at all he arrives to our emergency within 3 hours, then only the pralidoxime or whatever the oximes we are giving, acetylcholinesterase reactivators, that is going to help us. If the patient is coming to us after 12 hours or 15 hours, it is not going to help us, because by the time the patient reaches us, the acetylcholinesterase enzyme has already undergone aging and it is irreversibly inhibited by the organophosphate compound. If the patient has consumed ethyl compound, the half-life of that ethyl compounds are 33 hours. So we have a buffer period of 33 hours for us to give oximes in ethyl poisoning. If the patient has consumed these atypical compounds like profenophos and prothiophos, the half-life of these compounds are just 30 to 60 minutes. So if the patient is bringing a bottle of profenophos with a history of consumption of this compound 3 hours or 4 hours, then it's of no use giving oximes in this patient. It is not at all going to act, because by the time the patient reaches it is already undergone aging, and the organophosphorus has formed an irreversible inhibition over the acetylcholinesterase enzyme. So this is, I think, one of the most important slide in this presentation. We should know what compound patient has taken, so that we can expect the prognosis, we can expect how soon the recovery will be, and we can prognosticate the patients. So coming to the clinical features, a rule of 3, based on symptoms and signs, can be divided into 3: muscarinic symptoms, nicotinic symptoms, and central nervous system symptoms. Based on the timing of consumption, timing of presentation of the poisoning, it can be divided into acute, delayed, and late. Acute is the patient presenting with muscarinic symptoms within 1 day. If the patient presents with symptoms after 1 day up to 2 weeks, it is delayed. If the patient is presenting with features of nicotinic symptoms or muscarinic symptoms after 2 weeks, it is late OP poisoning. Based on the organs, it can be classified into predominant cardiovascular manifestations, respiratory manifestations, or central nervous system and peripheral nervous system manifestations. So this is the rule of 3, dividing the clinical features based on the symptoms, timing, and organs. There are 2 more terms, which is DOPE, delayed organophosphate encephalopathy. This encephalopathy usually occurs after 5 to 7 days of organophosphate consumption. We had got a patient who was totally fine on admission. On 2 to 3 doses of atropine, he got fine. But after 5 to 7 days, he started developing altered sensorium, followed by he lost his consciousness. We had to intubate him, and he typically mimicked like a brain dead patient. But we remained patient, and his reflexes started gaining after around 2.5 to 3 weeks, and after 4 weeks he got tracheostomized and got discharged. So dope is one of the brain dead mimic characteristic feature in organophosphorus poisoning, which usually occurs after 1 week. And the fifth term is COPIND, which is chronic organophosphate-induced neuropsychiatric disorder, which is usually seen in farmers who gets exposed to very small amounts of organophosphorus for a very longer duration of time, maybe for months or years. They usually present with some extrapyramidal symptoms, tremors, anxiety, or some neuropsychiatric features. They usually do not present with muscarinic features, so it is very difficult to diagnose this chronic organophosphate scenario. So based on the symptoms, we are all aware what are the muscarinic symptoms on all the glands and organs. On the glands, it is a sludge, all the secretion, salivation, lacrimation, urination, defecation, vomiting, so diarrhea will be there. Organ-specific muscarinic symptoms will be severe bradycardia and hypotension, and meiosis followed by bronchoria and bronchospasm, leading to respiratory failure. What are the nicotinic features? Based on the central nervous system and peripheral nervous system and neuromuscular junction, it leads to severe neuromuscular palsy, fasciculations, and the classical intermediate syndrome because of the predominating nicotinic symptoms despite absence of muscarinic symptoms. So it usually occurs after 48 to 96 hours after the consumption of organophosphate poisoning, where the muscarinic symptoms usually subside and the nicotinic symptoms predominate. And what are the central nervous system features? There are 3 types of palsies that can occur in an organophosphate poisoning patient. Within 24 hours, usually type 1 palsy is seen, where respiratory muscle weakness can be seen. Patient can have anxiety, restlessness, and patient can through generalized seizures. After 24 hours till 2 weeks, the patient can develop type 2 palsy because of persisting nicotinic symptoms characterized by extrapyramidal symptoms, fasciculations, tremors, and proximal muscle weakness, ocular muscle weakness, neck muscle weakness, and respiratory muscle weakness. This type 2 palsy troubles us a lot in ICU patients because it becomes difficult for us to wean off them from the ventilator. Type 2 palsy is typically seen in intermediate syndrome patients. Type 3 palsy, which is usually seen after 2 weeks, which is predominated by neuropathic features where muscarinic symptoms are hardly seen. And again, here tremors, patient having altered sensorium, delirium, extrapyramidal symptoms, and fasciculations along with weakness. That again is going to extend the stay of the patient. So this is a nutshell of all the clinical features of the organophosphorus poisoning. These are the 5 terms we must know when encountering an organophosphorus poisoning. The commonest clinical manifestation is acute cholinergic crisis, which occurs within 24 hours, where muscarinic symptoms usually predominate. What are the 4 symptoms the patient usually present to us is all the muscarinic symptoms, sludge, along with bradycardia, along with an altered sensorium, garlic smell, which is the typical smell of organophosphorus poisoning, and meiosis. And these are the 4-5 features which are commonly seen in acute cholinergic crisis patient, which occurs within 24 hours. Second term is the intermediate syndrome, which usually occurs 48 to 96 hours after the consumption, predominated by proximal muscle weakness, neck muscle weakness, shoulder weakness, and diaphragm palsy leading to respiratory failure. So the stay of a patient prolongs by at least 2 to 3 weeks. Third term is the opioid-induced delayed neuropathy, which is characterized by the distal weakness. It usually occurs after 2 weeks of consumption, characterized by paresthesias, tremors, anxiety, and can even lead to coma. Here, the fourth term is the DOPE, that is delayed organophosphate-induced encephalopathy, which also usually occurs after 5 to 7 days of the consumption. That usually presents with encephalopathy mimicking like brain dead patient. Fifth term is the chronic opioid-induced delayed neuropathy. It is usually dominated by neuropathic or neuropsychiatric manifestations. Hardly muscarinic symptoms will be seen. So these are the muscarinic receptors. We are aware of M1 to M5. This is the classification of clinical manifestation based on the timing, acute, delayed, and late. We already discussed this. This is the commonest manifestation where the patient presents with all the muscarinic symptoms: bradycardia, meiosis. So what is the emergency team management on admission? First and foremost is the detailed history. What did he consume? When did he consume? And how much he has consumed? To look for the typical garlic smell of the patient. And even if we are doubtful about the history and the smell, then we can do an atropine test by giving 1 to 2 milligram of atropine and test for reversal of the cholinergic symptoms, whether it is occurring or not, and send RBC anticholinesterase, acetylcholinesterase level if at all available and feasible. It is not a must because it is more of a clinical diagnosis rather than a laboratory diagnosis. So the triad of our management is ABC, atropine and AIIMS. That's all in a nutshell. First is always A, B and C. Whatever the case it is, whatever poison it is, first focus will be on ABC, airway, breathing and circulation. Along with the universal precaution, because if we touch the patient and if it gets contaminated, we get contaminated, we can get diarrhea and vomiting. So universal precaution is a must. Immediately remove all the clothes from the patient's body, wash the patient with soap and water, and gastric lavage should be done only if the patient is awake. If the patient is semi-conscious or unconscious, do not do gastric lavage. Better to secure the airway, intubate the patient, take him on mechanical ventilation, and then do a gastric lavage. If at all patient reaches to us within 2 hours of consumption, then activated charcoal might have some role. If the patient comes later, then activated charcoal is not going to help us much. Most of the patients present to us with severe hypovolemia and electrolyte disturbances because of severe vomiting and diarrhea. So first step, this simultaneous correction of volume and electrolyte should be going on as a first step. So the first step is to put the patient in the lateral position, head down position, prevent aspiration. If the patient is semi-conscious or unconscious, immediately intubate the patient and then only do a gastric lavage. Otherwise, better not to attempt for the gastric lavage. Second most important step is giving atropine, which is the drug of choice for organophosphorus poisoning. The dose is 1 to 3 milligrams stat, followed by every 5 minutes. We can double the dose. Every 5 minutes it should be repeated until atropinization is achieved. We'll see what are the atropinization targets in the next slide. Third step is giving oxime, which is otherwise called the acetylcholinesterase reactivators. Though it has weak anticholinesterase activity, they help in reversing the acetylcholinesterase enzyme activity, thus neutralizing the organophosphate poisoning effects. So first is ABC. Immediately put the patient in the left lateral position and do an oral suction if at all patient is having secretions. And third step is the gastric lavage only if the patient is awake, and to avoid gastric lavage if the patient is semi-conscious or unconscious. Lateral positioning, oral suction, we should wash the whole body because it gets secreted in the skin even. We should avoid trials in a semi-conscious patient. We should get a gastric lavage done, and intubation should be on priority basis, and start bombarding atropine. So once we start giving atropine, our targets will be heart rate more than 80, systolic blood pressure more than 80, and clear chest, in the sense bronchuria should settle down, and sludge, all the sludge symptoms will be settling down. These are the 4 criteria mandated to say atropinization has achieved. One point which has been removed recently is the pinpoint pupil. The pupillary size normalization is not required to say atropinization is being achieved. One more confounder in achieving atropinization is tachycardia, because most of the patients are hypovolemic. That can cause tachycardia. In the initial phase, the patients are quite in a fear of dying, so the patients are anxious. That can cause tachycardia. If at all patient has aspirated, it can cause hypoxia leading to tachycardia. These are the 3 common confounders where the patient can present with tachycardia along with other muscarinic symptoms. So tachycardia should not be a contraindication for giving atropine, and it should not be the only criteria to decide whether to give atropine or not. And once the atropinization is achieved, 10 to 20% of that atropine dose should be given per hour infusion till 24 hours to 48 hours, and can extend it even up to 5 days. Always watch for the atropine toxicity, which includes fever, tachycardia, delirium, constipation, and urinary retention. If at all patient develops atropine toxicity, we can consider holding the atropine for a short duration of time, and in that period, if the patient has predominant muscarinic symptoms, we can consider glycopyrrolate. Even though glycopyrrolate is a tertiary compound which does not enter central nervous system and it cannot tackle the central nervous system effects, it can handle all the muscarinic symptoms in the peripheral nervous system. Dose is 7.5 milligram diluted in 100 to 200 ml NS, running in an infusion, and the dose should be titrated based on the symptoms. So the third part of the management is this acetylcholinesterase inhibitor reactivators. The commonest drug which we use is pralidoxime. Apart from this, obidoxime and trimidoxime are the other drugs available, but this pralidoxime is quite cheap and easily available. So coming to how does AIIMS act? This is the acetylcholinesterase enzyme. We all are aware that the organophosphate compound sits on the esteric side, so the anionic site is let free. So on giving AIIMS, this AIIMS starts binding to the anionic site, and it forms a strong bond with the phosphorus atom of the organophosphate compound. So this AIIMS organophosphate compound slowly starts dissipating from this acetylcholinesterase enzyme, and even the esteric site is set free. So now the acetylcholinesterase enzyme is ready to neutralize or hydrolyze the acetylcholine, so the muscarinic symptoms improves. Again, what are the common questions while giving AIIMS? Should I give? Yes, you should give. When should I? How much should I give? 30 milligram per kg over 20 to 30 minutes, first bolus dose, followed by 8 to 10 milligram per kg per hour infusion. If we consider a 60 kg male, the bolus dose will be around 1.8 to 2 grams over 30 minutes, followed by 500 milligram per hour infusion. Up to 48 to 72 hours we can continue. Recent literature advises us to continue for 12 to 24 hours after the atropine has been stopped. So when should I give? Again, it depends what compound the patient has taken, whether it is a methyl, ethyl, or an atypical compound. If it is an atypical compound, do not give AIIMS. It is not going to work. If it is a methyl compound, if the patient has reached to us within 3 or 4 hours, then we can give AIIMS. It might work. If it is an ethyl compound, we have got a buffer period of 33 hours of half-life for the enzyme to get aged. So in ethyl compounds, we must give. And coming to carbamide poisoning, which is a close mimicker of organophosphate poisoning, paradoxins are not supposed to be given because carbamide binds both the esteric and the anionic site, unlike organophosphate poisoning, which binds only to the esteric side. So there is no site left on the acetylcholinesterase enzyme for the AIIMS to bind. So what happens in carbamide poisoning if we give AIIMS? The weak anticholinesterase activity of the AIIMS will predominate, and the muscle weakness will get worsen. So in carbamide poisoning, it is contraindicated. We should not be giving AIIMS. So when I should not give? In carbamide poisoning, or if the patient is coming after consuming profenophos, like atypical organophosphorus compounds. How long should I give? 48 to 72 hours, at least 12 to 24 hours after stopping atropine infusion. So these are the 4 compounds which we encounter commonly to decide whether to give AIIMS or not in the emergency department. So this is all about the management, starting from ABC, atropine, and AIIMS. So other tried and tested therapies which are still in vein, FFP, albumin, and lipid infusions, all these 3 were attempted and believed that it will bind to the organophosphate poisoning and that will get excreted to the kidney, but the evidence is very, very less and it is not advocated. Hemoperfusion, again, it was in 1 or 2 randomized control trials. Hemoperfusion has been tried in patients who came to emergency department within 4 to 6 hours of consumption. So it had shown certain benefits. Again, the evidence is less, and the role of antioxidants, clonidine, is very, very less. So it is not recommended. So these are the take-home bullet points: history of the compound, the timing, and the amount of the compound is very important. Second point is the garlic smell along with sludge symptoms with bradycardia and myiasis. This is considered to be the tetrad of organophosphorus poisoning. So regarding the management, ABC stands first, followed by the atropine, which is the drug of choice, followed by the AIIMS. We should know when to give, how long to give, and when not to give. Thank you.
Good afternoon, everyone. I am Dr. Sohail Alikal, second year PG resident of Department of Forensic Medicine and Toxicology, AIIMS Bhopal. Here I am going to present on the topic medico-legal issues and trends of autopsy findings with ingestion of organophosphates. In this presentation, first of all, I would like to start with a brief introduction of the scenario which is happening in our country. Then we will look at some in detail about organophosphates. Then later we will talk about the medico-legal aspects, autopsy findings, and later I would conclude the presentation. As an introduction, the National Crime Records Bureau of India, according to the records of National Crime Records Bureau of India, in 2019 and 2020, the number of suicides in India were 1,39,000 and approximately 1,53,000, of which approximately 25% of which were by poisoning. And various studies in India also shows that of the poisoning cases, for a range of 20 to almost 70% is done by pesticides. And in it is not only suicides, but there have been also cases of accidental poisoning, such as one happened in Kerala, where parathion was accidentally leaked into food particles, and subsequent poisoning were occurred. Moving on to organophosphates, these are widely used as pesticides in agricultural parts of the world. It usually has physical appearance of dust, granules, or liquids, and the absorption of organophosphates in cases of poisoning usually occurs through transdermal, transconjunctival, inhalational, gastrointestinal, urinary, genitourinary mucosa, and direct injection. These are the common sources where we can find organophosphates. Since it is widely available, we can see it in garden sheds, particularly in insecticidal preparations, surface and room spray baits for cockroaches. Example is chlorpyrifos. In shampoos for lice, pet preparations, industrial insecticides, or even it is used in terrorism or warfare as nerve agents. Further, the organophosphates are can be classified according to their toxicity. Here I have highlighted some common organophosphates, which like parathion, which has high toxicity, which is like 50 to 500 mg per kilogram, can cause death in 50% of the cases, and chlorpyrifos and malathion, which has moderate and low toxicity. Moving on to the medico-legal aspects, as a general guidelines for all types of poisoning, if the case comes to our institutes or our health setups as an emergency, the first priority should always be resuscitation and stabilization, and the consent should always be implied in these emergencies. And registration of MLC and police intimation is mandatory under CRPC 39. And the failure to do so may invite persecution under section 176, which has a penalty of up to 6 months or 1,000 rupees fine, or both, or under section 202, which has a punishment of up to 6 months fine, or both. And also the discharge, transfer, or death of the MLC case should also be informed. Moving on to the medico-legal evidence handling in cases of suspected poisoning. The main articles which should be preserved are gastric lavage, gastric contents, vomitus, and the clothings the suspect or the patient was wearing, or any other relevant body fluids. The fluids collected should be preserved and handed over to investigating authorities, and it should be identified, sealed, and labeled properly. A failure to collect or destruction of loss of such an exhibit can be punishable under 201 of IPC. Here, the punishment is according to the offense which is being committed. That is, if the offense is punishable by death, the person who failed to collect or causes the loss of this exhibit can get a punishment of 7 years plus or minus fine, and in life imprisonment, and punishment less than 10 years, it can be up to 3 years and up to 2 years of imprisonment respectively. And moving on to autopsy findings. In autopsy findings, these are the expected autopsy findings, which are in external findings. We are more likely to get an characteristic odor of garlicky or kerosene-like smell, which is attributed to mostly to liquid formulations of organophosphate, because it is mixed in kerosene or other petroleum products. And others are frothing at mouth, cyanosis of extremities, and constricted pupils. And in internal examination, congestion of GI tract, the garlicky odor of contents, pulmonary and cerebral edema, and general visceral congestions are seen. In our institute, we had 3 autopsy cases of confirmed organophosphate poisoning. And in 2 of these cases, the patient died in 1 day, and one of the cases the patient died after 4 days of treatment. But in these cases, we were not able to find the expected or the external findings. Here, the external findings which we expected were either not appreciated or it was not present. These were the cases. And in internal findings, we were only able to find generalized congestion. There were no specific findings which could be attributed to organophosphates. These are some pictures of the internal organs, and these are the stomach contents. Also, it is said that some of the industrial organophosphate has a greenish coloration added to it, so we may get a greenish colored content, but it was only one case in the 3 cases where had this presentation. And moving on, in conclusion, since the organophosphate cases have a non-specific autopsy findings, the preservation of evidences is important for identification of compound. So we have to keep in mind that it is more important to preserve the evidences much more than that of autopsy findings, and mostly the compounds are confirmed by doing analytical techniques such as chromatography. These are my references. Thank you.
Good morning, all of you. Today we will discuss about toxicohistopathology of organophosphate poisoning. I am Dr. Jay Kumar Chaurasia, Associate Professor, Department of Pathology and Lab Medicine, AIIMS, Bhopal. The histopathological findings in an organophosphate poisoning depends upon duration of exposure of the poison, dose of exposure, which may be a slow dose or an acute poisoning, and also on the type of organophosphate, which may be a volatile or a non-volatile form. It also depends on time since death. Now coming to the basis of histopathological alteration in tissues due to the organophosphate poisoning. It occurs due to the irreversible inhibition of acetylcholinesterase and generation of reactive oxygen species and production of DNA alteration or the DNA defects. There are, in the literature, there are few articles which demonstrate and document the histopathological finding in organophosphate poisoning. These are some of the original articles. These articles stress on the fact that liver, kidney, and endocrine organs such as adrenal and thyroid are mostly affected in organophosphate poisonings, although lungs, skin, oral mucosa, pancreas, and brain can also be affected. These all organs are affected because of the metabolism of the organophosphate. Liver is basically involved in the metabolism of organophosphate, resulting in accelerated glycogenolysis, proteolysis, and lipolysis. Similarly, kidneys are also involved as they eliminate the organophosphate poison depending upon its liposolubility. Endocrine organs are also involved as glucocorticoid and catecholamine secretions occur, resulting in exaggerated cholinergic stimulation. Lungs can also be affected because of the cholinergic overstimulation, and which may later result in respiratory arrest. So coming to the first histopathology, which is of liver, which is mostly affected in organophosphate poisoning. The basic histopathological finding includes centrilobular vein dilatation, congestion, sinusoidal dilatation, vacuolar degeneration of hepatocyte, reactive changes in hepatocytes, centrilobular necrosis, bile stasis, periportal inflammation, and Kupffer cell hypoplasias. All these pictures I will be showing on the histopathological slides. So this is the first slide. You can see that there is a central vein which is very much dilated. In both these pictures, you can see that these veins are dilated, surrounded by the hepatocytes and sinusoids. This is on the higher magnification. You can see these sinusoids which are dilated and congested in picture 1 and 2 both. And there is evidence of cholestasis also in the form of brown pigment in the cytoplasm of the hepatocytes. Similarly, this picture shows that there is periportal inflammation. So this is a central vein surrounded by chronic inflammation in a periportal region. Now this is showing the bile ducts. Both pictures are showing the bile ducts surrounded by the chronic inflammatory cells. So there is inflammation around the bile ducts. This picture shows the hepatocytes with cholestasis. Now coming to the kidneys. Kidneys are also involved in the organophosphate poisoning. There are changes in the glomerulus, tubules, and interstitium. The kidneys are mainly involved in the elimination of the byproducts of the metabolism obtained from the liver. So in the glomeruli, we can see there is capillary dilatation and congestion. One of the important features is the glomerular atrophy. In the tubules also, we can see acute tubular injury, necrosis, dilatation of the tubules, cloudy swelling, peritubular congestion, hyaline cast, which is called as thyroidization, and in the interstitium we can see inflammation. I will be showing these pictures on the histopathological slides. This is the first slide. You can see that these are the glomeruli. In the first picture, you can see two glomeruli. One is the big one and the other one is a smaller one with lot of empty space. So this is an atrophic glomeruli. The second picture shows the higher magnification of that atrophic glomeruli where the capillaries are retracted and there is atrophy of the glomerular tuft. Surrounding which are the tubules. You can see that the tubules are also dilated in this picture. Similarly, this picture shows glomeruli where you can see that there is capillary dilatation of the glomerular tuft. So this picture shows the tubules. The tubules show thyroidization or the hyaline cast. You can see on the low magnification that these are the casts and these are the secretions and the hyaline cast in the tubules, which is one of the feature of organophosphate poisoning. Now again, this picture shows that the tubules are highly dilated and there is the lining epithelium of tubules is not showing the nucleus. So these are like, you can say that there is dilatation of tubules with cloudy swelling as well as acute tubular injury. Coming on to the lung. Lung may show alveolar damage, septal thickening, septal inflammation, congested septal capillaries, peribronchial inflammation, congested large vessels, hemorrhage, and extravasated RBCs. Lungs are basically involved in the organophosphate poisoning as they most of the time there is cholinergic stimulation and later when there is downregulation of the nicotinic receptors, this leads to the respiratory arrest. So these are the pictures which we can see that there is diffuse alveolar damage in the lung parenchyma. The alveoli of the lung are usually separated by the septa. Here the septa are destroyed and the alveoli coalesce to form the big spaces. So there is a diffuse alveolar damage which can be found in the lung parenchyma. So this is the same picture. You can see that this is a normal lung parenchyma on the lower side, and on the upper side you can see that there is diffuse alveolar damage. The lung can also show edema and you can see on the histopathological slide that the lung alveoli are filled with the proteinaceous alveolar fluid. Coming on to the septa are dilated, congested, and you can see that the septal vessels are congested in both the pictures. In these pictures, however, we can also identify megakaryocytes. These megakaryocytes can be seen in many other causes of death, such as including poisoning or any exphyseal death. So this megakaryocyte also signifies that there is restriction of the oxygen exchange and the gaseous exchange resulting in the megakaryocyte which are visible on histological sections. So this picture shows that there are congested vessels. This is a large vessels which is thrombosed and adjacent alveoli showing the alveolar damage or the diffuse alveolar damage. Coming on to the endocrine organs. Endocrine organs mainly are adrenal and thyroid and pancreas, which can be affected by the organophosphate poisoning depending upon the time of exposure and the dose of exposure. Adrenals may show congestion, inflammation. That there can be a vacuolar degeneration of the fasciculata cells and chromatin margination of the cells of the adrenal. So these are histopathological clues by which you can say that the poisoning has occurred. So we will be seeing the pictures. So these two pictures show that there is vacuolar degeneration of the fasciculata cells. This cytoplasm is having vacuoles. This is the picture from electron microscopic picture where you can see that this is a fasciculata cell where the cytoplasm shows vacuoles and this is the nucleus. Similarly, this is also showing that there are chromatin features in organophosphate poisoning, which is particularly chromatin margination. You can see that there is chromatin which is marginated towards the periphery of the nucleus. Similarly, coming to the thyroid may also show that organophosphate poisoning feature. There is usually a reduced colloid in the follicles, foamy transformation of the colloid, and mitochondrial damage. Now, this picture shows that these are the thyroid follicles which show reduced colloid inside their lumen. And this second picture, you can see that this is a thyroid follicle which is having the foamy histiocytes inside the lumen and which is called as the foamy transformation of the follicles. So these are peculiar findings which are mentioned in the literature in organophosphate poisoning. Similarly, there is a mitochondrial damage in thyroid also. This is an electron microscopic picture which shows that this is a mitochondria which is damaged here. Now, any organ can also be involved, such as pancreas, stomach, skin, which are in direct contact with the organophosphate poison. These may show changes such as necrosis, apoptosis, abrasions of the mucosa. My take-home message is that histopathological findings are of immense help in correlating and confirming the clinical and autopsy finding. Almost all organs can show histopathological changes in organophosphate poisoning depending upon the exposure, duration of exposure, and the dose, and also depend upon the type of organophosphate poisoning. It can aid in establishing the cause of death where other circumstantial shreds of evidence are lacking. As many organs as possible should be subjected to histopathological examination to see the changes and confirm the cause of death. With this, I end my session. Thank you.